Welcome to the Autism Microbiome, and we are going to be looking at making the gut-brain connection with the GI map. I'm super excited you all are here with me today, so we will get started. My name is Greer McGuinness. I'm a registered dietitian, certified detox specialist, I'm a master herbalist, Lyme practitioner, and I'm an autism mom. I have two publication research studies, one on the work on sulforaphane treatment for autism spectrum disorder, and the second is a chapter contribution of metabolic approaches to the treatment of autism spectrum disorder, which is a Springer book that you can get at any time, which I love. The book is absolutely amazing. I am a lab educator with GI Map as well, and I specialize in autism, ADHD, gut health, detoxing, and complex pediatric cases. So we're going to be covering a broad spectrum of topics today. We're going to be looking at the research on the gut and autism, symptoms of gut imbalances in autism, the feeding challenges and how they impact the diet of the autism gut. We're going to look at decreasing in digestive support, H. pylori and ammonia, some leaky gut trends, and we will wrap up with a case study at the end. Now, the narrative has been for quite some time that autism is just a genetic component. It's something you are born with. And we have looked around for research, and most of the research, if you look at the bottom left-hand side with the graph, you can see in the past around like 10 years or so, we've had an explosion of research looking at other types of, impacting the children with autism and ADHD specifically. And we have known now that gut microbiome in autism has reached a whole new high, especially in functional medicine. We know this more now than ever. So when people say, autism is only genetic, we need to kind of start changing that narrative and say, hey, let's look a little bit deeper, because there is research out there to show that the gut-brain connection and how the gut can impact a child and their cognitive development and behavior is pretty sound. So definitely take a look at a lot of that research that's out there. And as you can see, there's over 1,000 published research studies currently on the microbiome and autism spectrum disorder. With that gut-brain connection, we now know that there is this synergistic effect between how the gut is developed and how it impacts the brain. We know with research the synaptic neuron development between the ages of 1 and 2 is one of the greatest amounts of impact for a child, and that gut-brain connection actually goes at the exact same time. So as the synaptic neuron development is occurring and it's peaking between the ages of 1 and 2, the gut microbiome at that same exact time is developing, and they go parallel to one another as they are developing. So anything that could affect the gut can affect the brain and vice versa. So we know that things like diet, medications, different types of comorbidity and graphic location for environmental toxins and different types of GI symptoms can impact not only the gut microbiome, but alter the brain, especially due to that brain development during those peak times. Believe it or not, there's up to about 91% of kids on the spectrum who have some type of GI comorbidity disorder. I see this a lot in my practice, and speaking with these patients, it can vary from child to child. These symptoms can be anything from the most frequent, in majority of patients, about 80% would be constipation, diarrhea, abdominal pain, reflux, vomiting, gassiness, bloody stools. With children, we don't always, they can't tell us that they are hurting, especially in autism spectrum disorder, because most of them are nonverbal. So we do look for telltale signs if they're pressing up against a type of furniture, or they have those big Buddha bloated bellies. Those are those key symptoms that on the outside there is a problem. We can see that. But a lot of times I have patients that poop normally and don't really have GI symptoms that we can truly tell until we do a GI map or a stool test and kind of really see what's going on inside their gut. So even if they don't have that outward symptom that there's something wrong, internally there can be something wrong, and they just can't verbalize that to you. And many times things like reflux and some abdominal pain get often missed because their children can't tell us. And GI issues with kids can be linked to so many different types of behaviors. And this is just a list of behaviors that I have seen and that literature has also reported, with things like sleep disturbance and behavior. They could have horrible rage, meltdowns, head banging. My son had head banging. My son had meltdowns when he was uncomfortable and in pain. Self-harming behavior is a very hard topic to explain to parents of why their kid can't, why their kid is self-harming because they're in pain. Poor weight gain, poor muscle tone, and all of these can be linked to abnormal GI issues with that constipation, diarrhea, gas, bloating, etc., reflux. All of these symptoms can lay into why they're having those GI symptoms. So they are connected. We don't see that as a problem. Even picky eating, we're just like, oh, they're a picky eater. But if they're severely constipated, they're likely not going to eat. So many times if a kid is just having a poor appetite, it could be because they're severely constipated and they're not able to pass any stool. So underneath that, even if we have kids on the spectrum that have some type of issues with symptoms of digestive dysfunction, it doesn't just stop at the symptoms of the outward symptoms of what we're seeing. There can also be inward symptoms that are also impacting how the whole entire body functions. Any type of digestive insufficiency or digestive dysfunction can cause food allergies and sensitivities, enzyme deficiencies, mucus and blood of undigested food, pain, leaky gut. It can damage the microbiome, decrease our stomach acids, and we're going to talk a lot about this. Impact how we absorb our nutrients, cause SIBO, elevated histamine levels, and it can even impair our methylation cycle when it comes to the digestive tract. So just that issue of the GI system, causing some symptoms, there's that underlining. It can cause so much more than what we're actually seeing on the surface. This was actually a very interesting study that was done back in 2011 that looked at 58 children on the spectrum and versus 39 healthy individuals. And they were looking at the GI, their gut with stool testing, and they did test them for things like bacteria, yeast, inflammatory markers, secretory IgA, elastase. And what they found was that those on the spectrum actually had significant correlations of GI issues with severity of autism behaviors. So the worse their gut score was and the worse their gut was, the more severe their autism symptoms actually were. So this was, like I said, a study from 2011 showing that we started looking at the gut, that far ago, where we're now seeing that, and I see that as well. The worse the gut, the worse the autism and the autism symptoms. The autism microbiome differences, they're in functional medicine with this biomedical interventions with autism and ADHD. There's biochemical differences, like no different than we're looking at oxidative stress or, increase of reactive oxygen species and things like that. We can actually see that there's actually pretty vast differences between the autism microbiome and that of a neurotypical healthy individual. Things from increased permeability and leaky gut, inflammation, decreased digestive enzymes and insufficiency, increased opportunistic overgrowth, altered composition of intestinal microbiota, and dysregulated gastrointestinal motility and secretion. So we know that kids on the spectrum have these varying differences versus neurotypical healthy individuals. Most of these studies will say at the bottom that research findings are inconsistent across studies. And that does make sense when you do look at children on the spectrum and what their diet is, because every single person on this planet will be eating something different. And when we're working with kids on the spectrum, they are 5 times more likely to have developing feeding problems. They will refuse specific whole food groups. They won't eat anything green. They won't, touch anything that is too hard or too soft, too salty, too spicy. They could have these very selective feeding specialties with what they're consuming. And I've had kids that will eat some random things and not other things. And, I had one kid that loved beans and olives and, but he'll refuse anything else that wasn't beans or olives. So it depends what these children are eating, which makes sense of why the consistency of research across the board isn't always going to be as sound as we would hope. But when I work with providers or I work with patients, I always do a 3-day calorie count, intake, food charting to actually see what these children are eating, where the gaps might be, especially if I'm interpreting a test result to somebody. It does help to put all of that into place of saying, okay, this is low and this is low. It could be why that when you looked at their diet, they were not consuming X, Y, and Z, so that we know we have to bridge the gap until we can get them to get those foods. So most kids on the spectrum, I would say probably 90% of the kiddos that I've worked with are really picky eaters. Some even have ARFID, which is avoidant restrictive feeding intake disorder. My son has this, and it goes beyond just being a picky eater. It's actually a psychological eating disorder. So we do need to be careful with helping our kiddos, and we really need to use that as a foundation piece when looking at the gut and then working with them and supplementation. Most of our kiddos are going to love beige foods, and that will be something you'll see a lot of when you do food intake studies, that they love anything that is beige and white because it's very consistent for them and they love consistency. A Ritz cracker from 1950 is going to taste exactly the same if you ate it from now versus 50 years from before. So they're going to taste exactly the same, or because the strawberry that you ate last week could be completely different than what you're eating this week. So the beige foods are typically high in fat, low in fiber. They're very calorie dense. There's very low nutrient value in them. And they're very unfavorable to the gut. They really don't provide the microbiome with any sort of beneficial aspect of what we're eating. We know that with adults, we usually tell adults, you need to eat 35, 40 whole foods per week in order to diversify the microbiome. And most of your kiddos on the spectrum are going to eat maybe 20, typically less than 15 or 10. So that diversity is lacking, and that's something that we need to also be aware of and work with either a speech or feeding therapist or somebody that can help these kiddos overcome those picky eating challenges. So one of the things that we're going to look at first is the lack of digestive enzymes. And like I said, when you're eating those beige and white foods, the lack of digestive enzymes is going to typically be something that I see very, very often. When we're looking at the test, we're looking at the steatocrit and elastase for fat malabsorption and digestive support. And I would say probably about 60% of the kiddos will have digestive insufficiency. It's a big, big, big piece that I see quite often in autism spectrum and ADHD with kiddos, because a lot of what their food intake is and what they're eating is not favorable to our digestive system. We know as practitioners we need things like bitters and herbs and things like that. And besides parsley on pizza, no kid's going to be like, hey mom, can you throw some arugula on my food? Like, that's not going to happen. So we need to assess their intake and then assess what's going on, because the hypochlorhydria that occurs is that breakdown, and it's so important. So when we don't produce hydrochloric acid, we are not able to break down our food or allow for that proper digestion of food. When you speak to your families, a lot of times I'll ask, like, hey, have you ever seen undigested food in their stools? And majority of them will say yes, because there is some type of insufficiency going on. They'll have issues with breaking down and absorbing mineral absorption. Your stomach acids are basically what I call like the open door policy, that if you don't have hydrochloric acid, you don't have that good stomach acids, you don't have anything to kill those pathogens, viruses, bacteria, and parasites. And now you have an open door policy where they're just going to come right in and make themselves at home. This is why when you see that overgrowth pattern, those bacteria, those parasites, you have to think hypochlorhydria at one point in time has occurred, and that they're not able to defend themselves against anything and any of those foreign invaders that are coming in. We need that hydrochloric acid to trigger the pancreas and the liver to secrete their enzymes. We need this to occur because we need for that proper food breakdown, but we also need that liver to create that bile that helps carry out waste. Things like heavy metals, mold, pesticides, excessive copper, fluoride, all of that needs to be supported by the bile. Most kiddos on the spectrum will have issues with liver and their methylation cycle, which means that their livers are not filtering correctly, they're not able to detox properly. And again, a lot of that has to stem back from that hypochlorhydria. We need to fix that main open door policy first in order to be able to move forward. Major risk factors for hypochlorhydria in the autism spectrum population has to do a lot of times with diet, that high sugar, poor protein diet, low zinc, stress, eating too fast, PPIs, antacids, and toxins. PPIs and antacids are actually really a big problem in this population as well. If you do a very good history, it's one of the first things I'll ask, are there any like acid reflux or problems with breastfeeding, formula feeding? A lot of them will tell you that they were on PPIs for quite some time, due to acid reflux. The baby was spitting up for a couple months until they maybe removed dairy or removed some food sensitivities. And the reason why this is such a problem, especially early on, is PPI use has been shown almost about 60% to develop SIBO. So if you have children with a developing microbiome that are compromised, they run a very big risk of developing that dysbiosis or SIBO early on in life, and that will continue to carry on during that brain development. So do a very good intake with your patients and ask about those PPIs and antacids. They a lot of the time will be a big correlation with the microbiome. And again, a lot of it also has to do with the diet too. Symptoms of hypochlorhydria, I'm sure most of you will know what these symptoms are like in adults. And for a kid, they could be very similar. However, the last four on the right-hand side are ones that I have seen in my own practice because, again, our children can't speak to us. They can't tell us a lot of times, hey, mom, dad, I'm having this heartburn feeling or reflux. They don't know. But what you will see a lot of the time would be clearing of the throat, some vocal stimming and making vocal noises a lot of the times, especially after meals, belching and hiccuping as well for those little ones because of the low digestive support that they're feeling. So again, they could still have the similar symptoms that an adult would, but with a pediatric patient, especially ones on the spectrum, those ones I find quite often with hypochlorhydria, and I do ask those specific questions as well. Now, sometimes there will be patients who their elastase might be normal, the steatocrit would be normal as well, and we will kind of say, hey, look, everything looks good, but there can be some potential low hypochlorhydria patterns here, where if we see a phyla really, really high, and again, asking that intake of, are you seeing undigested food? Are their stools really not what they should be? That there could be a hypochlorhydria pattern, and it just unfortunately at that time did not get picked up specifically, but it doesn't necessarily mean that their digestive system is normal. I would definitely take a look at what they're eating as well. And a lot of the times I will still do things to boost up their digestive support, whether it be with some herbals or some teas and stuff. It doesn't always have to be an actual enzyme, just to kind of get things flowing a little bit more. But there are some patterns that, you know, we need to look out for in case that we just don't see it right with that elastase all the time. This was another study that was actually really cool. They actually did a double-blind placebo with 101 autism kiddos, and they found after 3 months of digestive enzymes, there was a improvement in emotional responses, general impression, autistic scores, general behavior, and gastrointestinal symptoms. And I see that and more a lot of the times in my practice as well, because a lot of the times when your kiddo is not digesting things well, they're not breaking down that food, they're not getting nutrients that they need. And you could have them on some of the best the supplements in the entire world. If they're not digesting it and absorbing it, they're not getting it. So sometimes a digestive enzyme could be your super best friend in this particular instance, especially with kiddos on the spectrum. Now, I'm leading the hypochlorhydria into the H. pylori because a lot of times we will see low or hypochlorhydria with H. pylori patterns. And this makes a lot of sense when we're looking at the big picture for these kiddos. Now, I don't see this all the time, but I definitely can say I've seen my fair share of kiddos with H. pylori patterns and H. pylori symptoms. And it's never always what I think, because again, hypochlorhydria and H. pylori can have some similar symptoms as well. H. pylori, if you're not aware, is a bacterial infection that occurs in the stomach, and it actually is very common in early childhood. It is estimated that around half the people in the United States have H. pylori, but it doesn't necessarily mean that you're going to have symptoms. So many don't actually get sick from the symptoms, and some are born way more resilient than others. And your symptoms of H. pylori can be very similar to hypochlorhydria, including the same symptoms I talked about too, with the hiccuping, the belching, the burping, the vocal stimming. So just things to look out for as well when you're working with kiddos. It might be one, it might be the other, it might be both when you're working with kids and trying to treat and figure out what the plan is of what you're trying to do when you're looking at a stool test. H. pylori is a problem because it can pass from person to person. It can pass from husband and wife. Kids can pass this on to one another, saliva, vomit, stool. It can be pretty rampant. It can spread through contaminated water and food as well. It's present in about 50 to 75% of the world's population. And believe it or not, in children, the highest rate of infection is between the ages of 2 and 5 years of age, which I thought was really interesting. But it does make sense when you're around kids and you see them swapping water bottles all the time by mistake, or playing and things like that. So just something to keep in mind, that you might see this pretty often in some kiddos, but really sometimes only about 20% will actually have symptoms of real significant H. pylori. So just because you're not having those outward symptoms doesn't mean that internally it's not affecting you the way that, you know, in a negative light. H. pylori can produce 3 different types of enzymes. I'm going to focus mainly on the third one, but I wanted to put that there is 3 different types of enzymes that H. pylori can produce. The first 2, there's not a ton of research out there. We are not 100% sure exactly how the mode of damage that it could do. We do know that it can damage the gastric epithelium, the mucosa, etc. One of the most ones that we find and we know we have the most research on is the urease and ammonia. So H. pylori, as I explained earlier, H. pylori can actually thrive in an acidic condition by producing urease. Urease is hydrolyzed in the gastric juice, which breaks down urea into ammonia and carbon dioxide. The reason why ammonia can be a very big problem, not only because it's dangerous, but actually in kids, especially on the spectrum, there is an ammonia autism connection. So when ammonia and urease are present, it actually can continue to lower the acidity in the gut. So that's why many times you might see a very high H. pylori and a very low elastase level. And that makes complete sense because H. pylori has now taken over urease is present, and ammonia and carbon dioxide might be present as well. For kids on the spectrum, ammonia can be a big problem, and kids have tested higher than neurotypical kids when it comes to ammonia levels, even amino acid, which this most recent study from 2020 actually looked at 54 kids on the spectrum and 64 healthy individuals. And they found that kids with autism, their amino acid profile was statistically lower, and they did have more elevated ammonia level and oxidative stress. So we do know that kids on the spectrum are more susceptible to these types of infections and issues. And ammonia is one thing that many practitioners really don't know that much about or actually happen to look into until we get some more of this information out there, because this is a major problem of why we are testing for H. pylori. With ammonia levels, the issue here is a lot of the symptoms can mimic or kind of cross over with other things. Slurred speech, lethargy, irritability, blurred vision, convulsions, nausea, vomiting, neurological deficit, intellectual disabilities. Some patients will kind of look more like they're drunk, and that's from the high levels of toxicity of the ammonia levels in the system. So ammonia levels can be tested via blood test, which is very, very easy to do for kiddos, just to kind of see where their ammonia levels are at. And if they do have very high ammonia levels, that might be something to dive in a little bit further, especially with the GI map, and see what's going on inside their gut. Elevated levels of ammonia, especially in the brain, it's called hyperammonemia, and it can cause anything from impaired memory to decreased attention span, sleep-wake issues, brain edema, intracranial hypertension. There's a lot of issues that can happen with high levels of ammonia in the brain, especially with kiddos. So it's something that I am trying to explain more and more to families and to practitioners, that this is definitely something, if you do see H. pylori present, you definitely want to get these levels tested and see where this child or this kiddo is at and see what's going on. Now we're going to kind of jump into leaky gut a little bit, because we talked about hypochlorhydria, we talked about H. pylori, and all of that can break down and continue to break down the intestinal mucosa when it comes to the gut. And I'm sure a lot of you hear about leaky gut, but we're going to kind of look at the GI map when it comes into a few specific markers of how we can kind of help and what we're kind of looking for when we're seeing that. If you have our interpretation guide, this graph is in there as well, and it's an amazing graph if you're just looking to kind of look at intestinal permeability, low butyrate, short chain fatty acid, poor mucosa health, and you can see the specific type of, if certain commensals are high or low, how that could be fitting into the pattern for that particular person. And like I said, we're going to kind of be looking at that intestinal permeability marker and then the low butyrate short chain fatty acid production as well. This is on the second page of the test, where we're at the bottom, where it looks specifically at Akkermansia, Muciniphila, Faecalibacterium prunitzi, and Roseburia spp. And these are some of the trends that I see kind of often in my kiddos. And a lot of this has to do with specifically their diet. Unfortunately, again, with kiddos on the spectrum, their diets are varying. So some patients might have a perfectly fine Akkermansia, and others might have very low Faecalibacterium and Roseburia because they don't eat anything with resistant starches in them. So that's why, again, I do that 3-day calorie count to kind of see what's going on. And when we're looking at research, and it's very interesting the amount of research out there when you start looking up individualized commensals and how they relate to autism spectrum disorder, and if some are high or some are low, and you can definitely see where those correlations lie, especially with things like Akkermansia, Faecalibacterium were statistically lower in abundance with kids on the spectrum, which was very interesting. It said it was almost a 5- and 2-fold decrease, which was significant. So they definitely can see those beneficial microbes, those ones that really help protect the microbiome, protect the gut, and help us nutritionally, are statistically lower in kiddos with autism and ADHD. This one was a really interesting study too, looking at short chain fatty acids and kiddos on the spectrum. And this also had to do with the fact that the lower the rate of short chain fatty acids in kids on the spectrum, the higher their autism comorbidities and behaviors were. So the worse their gut with the lower the short chain fatty acids, the worse their autism symptoms were. Again, that correlation sometimes is really, really strong, and that's really, really interesting to see many of the times. So like I said, Akkermansia is super important. It's some of the ones that, you know, they're specific commensals that we have internally that really support that microbiome, that really support that barrier and inflammation, especially Akkermansia, which only makes up about 3 to 5% of the gut microbiome. It's actually a very small percentage, but it really does give a big bang. Kiddos with very low Akkermansia, I have seen, have issues with their GPL1 and their insulin resistance and having blood sugar issue regulations, inflammation, more likely to be constipated a lot of the times because that mucosa lining is not there. So Akkermansia could be a big problem. And with kids, depending on their diet, again, if you look at polyphenol foods, which usually is what boosts that up, they might be getting some of these on a regular basis, but they're not, you know, they might not be eating them all the time, because these are some of the more flavorful, you know, foods that can change those flavors. Like I said, blueberries and strawberries specifically, from a month ago to now, they could taste completely different. They could have been sour a month ago because it really wasn't the season, and in another month or so, they're going to be super sweet and everyone's going to love them and eat them. So sometimes it's that lack of food and that lack of specific type of food that they're looking for that could be a problem. Similar with Faecalibacterium and Roseburia, these are really anti-inflammatory. These two can do so many amazing things for the body. They're immunoregulatory, they're antimicrobial, they protect even the brain, they enhance those tight junctions for that leaky gut, they increase that mucus thickening of the intestines. And you know, when we break it down with those short chain fatty acids, acetate, propionate, and butyrate, a lot of kiddos are going to be low on Faecalibacterium and Roseburia because they're not eating resistant starches, unfortunately. There are specific types of foods that are out there, especially if you have a patient that might be doing like a low carbohydrate diet or a keto diet. A lot of the times their resistant starches are going to be super, super low. And that can always be a problem when we're looking at the microbiome. When kids are removing or people are removing whole food groups, it can negatively affect the gut if we're not careful. So definitely doing a test will definitely help look at some of the main components of what we're looking for. So that is part of pretty much everything that I really wanted to say about the autism gut and the microbiome and how those connections play a role. And now we're going to dive a little bit deeper. We're going to do a case study. This was a 5-year-old patient of mine diagnosed with autism and ADHD. They can communicate with only single words at a time, so like ball or cat, cup, food, etc. They have poor eye contact, difficulty sleeping, makes vocal stimming noises of clearing of the throat. And if anyone's kind of curious of what that is, it's kind of literally if you feel like you have like a frog in your throat. And with kiddos, they'll do that all day long. Bloated belly, constipated, goes every 4 to 5 days, which is pretty normal for many of my kiddos, and they have a limited diet. So we ran a GI map. And we can see H. pylori is relatively low. There was no virulence factors, but we definitely see a little bit of H. pylori. So again, some of the symptoms of the clearing of the throat that I always question whether it could be an H. pylori issue or could it be a digestive a low elastase, digestive support issue. So that's just one thing that I take into consideration of if I do need to treat, how long do I treat, and what are the levels. And there's no right or wrong here. I just want everyone to realize that there's no right or wrong. Some practitioners do just treat to make sure that it goes away and doesn't come back, and that's perfectly fine too, as long as you and your families are on the same page and looking at this and saying this is what we think we should do, because I think it would be in the best interest of the patient. So with this little guy, it was a discussion, but we wanted to look at some other things going on as well. And this is the second page of the commensals, where we could definitely see that he was trending more low than anything. It looks like more of a deficiency. We saw pretty low Escherichia SPP, which is the fourth one down. So, and this kid didn't eat any type of vegetables at all. So with the pH of the gut being maybe a little bit more acidic, we definitely saw low Akkermansia, low Faecalibacterium. So we definitely know that we have some issues there, possibly related to the constipation, any type of blood sugar issue, like I said, resistant starches, and then that bacteriophylla, which makes up 90% of the microbiome. We just have like nothing. Like this poor kid had like no gut sufficiency whatsoever. So we definitely wanted to boost that up as well. Had a lot of overgrowth, and that's not uncommon to see many times when kids have insufficiencies, that you'll see a ton of overgrowth. Think of it kind of as a weed in a garden. So if your positive commensals from the first page are your flowers, and this page is your weeds, and you go away for a week or two and you come back, the weeds will overtake the garden very easily if there's space, opportunity, and we're not keeping up on the changes of what's going on. So this didn't surprise me to see a ton of overgrowth, where I could see like, wow, this is causing a lot of inflammation. This could definitely be causing some of the constipation and the bloating issues. So I'm definitely always cautious when I'm looking at these, saying, okay, like what could be the possible symptoms. And I'm going to show you, I don't always go in directly for a kill phase. I might not, just start like adding tons of antimicrobials right away, because typically kids are not set up to start doing that yet. So I usually try to build them up first before I knock them back down with some of those antimicrobials. And if you can see at the top with the intestinal health markers, steatocrit and elastase. Steatocrit was high, so we have some fat malabsorption. The elastase is definitely low, so we're definitely having some digestive insufficiencies, not digesting their food well. The beta-glucuronidase is definitely trending a little high, so I'm definitely wanting to work on that liver. The segregatory IgA, definitely low. We definitely need to boost up that segregatory IgA and give that gut some more support. And then if you look further down, we can definitely see, some trending high eosinophil activated protein, calprotectin, zonulin. So we definitely are on the higher end for inflammation, and we definitely want to make sure that we're supporting this gut and building him up. Remember, so to me, this person is just completely defeated. They're completely on the lower end, and they have nothing to fight for them to get them in a positive way. So one of the things that we're going to start doing is working on their diet. I usually give my patients a list of like polyphenol foods and resistant starch types of foods. Like, hey, can we like start trying to expand their diet? And like, even with resistant starch foods, like cooking and cooling rice and reheating it is a resistant starch. You can make brownies with, black beans or pinto beans and things like that. You can make those things. It's about being creative with kiddos, because sometimes those supplements don't taste so good and they have this like really foul smell to them. So sometimes getting kiddos to take them could be a big challenge. So a lot of times I will try my best to work with the families on trying to get the foods in there. And then if we have to work on the supplement aspect, we will. We'll do digestive enzymes. We'll do some broad spectrum probiotics, work on polyphenols and butyrate type of supplements. Fish oils can be super helpful with kiddos. any type of immunoglobulin or colostrum to boost up that Sege. Quercetin is great. Antimicrobials can be super helpful. So when you're looking at the gut and you're trying to figure out like what is the best mode of, action first, like what should we be doing first? I usually first will attack the digestive enzymes, the broad spectrum probiotics, and boosting up the polyphenols and butyrate first, or short chain fatty acids. Those are typically in order what I will typically do with patients to make sure that we start the foundation, because people don't realize the digestive system will handle a lot of that pathogenic overgrowth. So if we can boost up that digestive support, it'll alter the pH and change the pH where it will affect the other pathogens that we have. So don't think that you need to throw the kitchen sink at them at first. Like, we don't need to go that route. We can start with just some basic concepts and basic interventions, because the gut wants to be better. The gut wants to have a stable environment. All it needs is just a little push in the right direction for a kiddo in order for it to go in that direction. You might not even get to an antimicrobial. You might not even need that if you do all these other steps first and then see where your patient's at. I mean, there are times that I've just done the first few for a couple months and retested, and the microbials change significantly, where the amount of overgrowth that we once had isn't truly there anymore. And that's a great thing, because the body can do a lot and handle a lot. So I don't always just run for antimicrobials in a kill phase first, because most of our kiddos are going to be in a flight mode. They're already going to be out the door, away from us, and we don't want to keep knocking them down and adding more and more things that could, just push them down even further. We want to build them up before we do any type of kill phase or any type of phase where, it will cause die off or toxins to be back into the system, and their liver isn't set up for that and things like that. So start working with your basics. Understand that, when we're looking at the autism microbiome gut, there are going to be vast differences, but again, they're not always going to fit perfectly to the literature that we have. So keep that in mind when working with patients, and understanding that just because, the literature might not support what's going on, it just really does depend on that particular child, their upbringing, any type of interventions, and and their current diet as we see it now. One thing that I always caution practitioners about is using leaky gut powders when working. And you could see from my protocol previously on the previous page that I didn't add any type of leaky gut or any type of powder or anything that had L-glutamine in it. The reason why is because kids with autism and ADHD typically already have elevated glutamate levels. So when you give a kid who has elevated glutamate levels L-glutamine, this will increase and make their anxiety, their hyperactivity, their stimming, and their tics like relentless. Like, they will just, I had a family. I was working with a older daughter and a middle son. We did a micronutrient test on both of them to detect where glutamate levels were, and the oldest daughter had very low glutamate levels, almost non-existent. Almost all of her amino acids were low. I did put her on a powder with L-glutamine in it, and it worked amazing for her. She actually started talking. She had more vocabulary. It was a beautiful thing. The middle child that we had been working with, the mom called me, I think, in like a week or two after she made the mistake of giving him the leaky gut powder, and she said, he is just wild. He can't sit still. He's not sleeping. Like, he's all over the place. Like, he can't calm down. And when I asked what happened, if she started anything, she said, well, I gave him the leaky gut powder because it worked so great for my daughter. And I said, but his levels were so much higher. Like, his levels were on the complete opposite. So doing this is, working against you 100%. And once you stop using it, within 2 to 3 days, levels should go down. So it's not anything that's going to stick. But this happens quite often, where I see a lot of practitioners, because they assume that for an adult, this is a great thing to use, which 100% it can be for an adult, but for a child, typically not. So we tend to say, you know, avoid the leaky gut type powders. If you need like an adaptogen or something to help support the gut, you could do like a simple DGL type of, you know, supplement instead that just doesn't have the L-glutamine or even glycine, which could also elevate glutamate levels too. Another issue with glutamate levels is the EMFs and computers and stuff. Believe it or not, kids being on iPads and EMF exposure also raises glutamate levels. So majority of kids on the spectrum are already heightened. So it's just something to completely avoid altogether. So that's usually my big tip for most people working with kiddos on the spectrum and ADHD. It's just not something that pretty much all of them will be able to tolerate unless you actually do a test for it. And that would be it for today. So I'm going to open it up to questions and we'll take it from there.
Thank you so much. So the first question, is the vocal stimming due to laryngopharyngeal reflex? I'm hoping I say that correctly.
Yeah, I think I understand where they're going. It could. I mean, there could be so many different reasons for vocal stimming. When we're like with my son, a lot of the times his vocal stimming actually occurred when I would trial a new supplement that didn't work well for him. He would start vocal stimming. It had nothing to do with his GI. Now, recently, my son was clearing of his throat and belching a lot. And when I repeated his GI map, his H. pylori was slightly elevated. And I was like, okay, well, that makes sense. So there can be so many different reasons for vocal stimming. I know when I'm looking at the gut and I'm working with patients, once I start treating those underlying issues, a lot of times it does go away. And for some, it does not. Some it's just, you know, the stim is like a tick, you know, that they do for calming and for sensory input.
Excellent. What do you recommend more, HCl or bitters?
So bitters can be tough because they're bitter, and most kiddos will not do bitters. I don't tend to reach right away for HCl. I will usually just do a straight digestive enzyme that has like amylase, protease, lipase in it, like very simple. I don't do oxbile, I don't do HCl. I just start them off on something very, very basic and then work with the families to incorporate things like bitters can be great if you can get a kiddo to take it, but so can be like milk thistle and dandelion root tea. I mean, those can be just as great and supportive for the gut and the liver. So you don't have to, it's personal preference for me. I don't think there's a right or wrong. I have seen people do HCl, but for me, I don't go that route because sometimes depending, again, I can't tell if things burn. So if they have high H. pylori and you put them on HCl, it could burn and they can't tell you that. So I'm kind of cautious with that, if that makes sense.
Okay. Next question. What role does elevated Morganella play in ASD?
Well, we could do a whole separate thing on like all the different types of species. A lot of this, I don't know specifically all the research on every microbial species, but with Morganella specifically, similar to like Pseudomonas and stuff, those are all your inflammatory pathogens. So anytime I see those, I just know that that kid has tons of inflammation and very well could be, you know, inflammation turned into mast cell and stuff like that. So it depends on that child and what else could be elevated as well.
Okay. What do you suggest when a child has low elasticities and elevated straighter sit on the GI map while taking gallbladder support and digestive enzymes?
So what do I feel if they're having low elastase and high steatocrit and they're already taking digestive enzymes?
And they're on the GI map while taking gallbladder support and digestive enzymes. Yes.
Yeah. So either there's a blockage somewhere, and you know it's not. So the problem is depending on the supplements, a lot of the supplements, like if you're giving someone oxbile, amylase, protease, lipase, it's not really telling the body, hey, you guys got to produce more, like let's go. you do need to have a diet component with it, and things like, you know, there could be a clog with the liver, there could be a clog somewhere, there could be something else that's impacting with the overgrowth. It's kind of like, you know, a game of guess who, like who, you know, it's hard to know what could be causing it, but sometimes I'll say switch up what you're doing, because they might not be responding to that particular product and supplement. Sometimes I see that a little bit more than anything, where it's just the product and the supplement just isn't doing what we need it to do, or maybe you need to do more of it.
Perfect. And then the last question for today, do you recommend an alternative to L-glutamine, or do you recommend GABA or L-tryptophan for high oh my goodness.
I think I see. Okay. Yeah, this one's a tough one. So do you recommend an alternative to L-glutamine, or do you recommend GABA or L-theanine for high glutamine? So when you have elevated glutamate levels, two things could be occurring. One, the person is just eating a ton of glutamate foods. Glutamate foods are your, you know, gluten, dairy, corn, soy kind of thing. So sometimes I'll be looking at that anti-gliadin gluten sensitivity and seeing if maybe there's, you know, is this a diet component? So that would usually be the first thing I do, is, you know, work on the diet component. But then also the second component with elevated glutamate levels is nutrient deficiencies, because you need certain B vitamins to convert glutamate to GABA. So if the gut isn't working, you're nutrient deficient, you're going to have elevated glutamate levels. If I need to work on the gut, and I obviously can't give that, I'll usually just do a DGL, which is like your licorice, slippery elm, aloe, etc., which is still what's in leaky gut powders too. It just doesn't have the glutamate in it as well. But GABA and L-theanine could be super helpful, but you also need other adaptogens to kind of work on that neurotransmitter pathway, like kava and stuff like that too. So it just depends what you're trying to attack, if you're trying to attack the gut or you're just trying to attack the neurotransmitters of the brain.
Excellent. Well, that's all the questions we have for today. We'd like to thank you for attending today's webinar and hope to see you at our next event. Have a great rest of your day.